discussion about stool. The first thing we talk about is occult blood, and I'm sure you're aware the reasons for testing for occult blood not only have to do with a screening for colon cancer, but if somebody comes in complaining of epigastric pain, chronic epigastric pain exacerbated by whatever, then you're looking at possible PUD or duodenal ulcer disease. I mean, most ulcerations occur at the duodenum. It's interesting that it has the name peptic ulcer disease. I think of peptic as the stomach, but most ulcers occur in the bulb of the duodenum. Anyway, if it's bleeding, it's going to turn an occult blood test positive. These are cheap tests to do. You need to understand that if you do a hemoccult, and the test is also called GUACC, G-U-I-A-U-A-C-C-U-A. It has an ugly name, spelling, GUACC. If you do this in clinic, you're not reimbursed for it. So if I do a rectal exam on you, if you come into clinic presenting with bleeding per rectum or weight loss or change in stool thickness or consistency, or if I have on my differential colon cancer, inflammatory bowel disease, peptic ulcer disease, and I'm going to do a screening in clinic, understand that you will not be reimbursed for it. The only way you get reimbursed for hemoccult is if you do a 3-card test and you send the patient home and they bring it back to the laboratory for analysis. One thing you need to keep in mind about a hemoccult or GUACC test, it does not work on vomit. So if a person says they've been vomiting blood, you can't use a hemoccult card for vomit. There's a specific card called a gastrocult you have to use for vomit. And you can't use a gastrocult card for your blood. Okay? So if you give somebody a 3-card series, note that on the card, the little card that they take home with them, there are 2 panels. In the little packet, they also have sticks, these wooden sticks. So what you do is you have the patient to poop into a thing called what's it called, a nun's cap? Is that what it's called? Huh? A nun's hat. A nun's hat. I don't know why they call it a nun's hat. It's a plastic thing that fits under the toilet bowl seat, and you poop into the little bucket. It's like a quart bucket.
It's a potty hat.
It's a pot, yeah. They call it a nun's hat.
Yeah.
Why? I don't know. Anyway, what you do is you take the little wooden stick and you stab the stool on one end and wipe it, smear it onto one square. And then take the stick, turn it upside down, and take the clean end and stab the stool in the other end of it and rub that over here. So you're testing the stool in 2 places, 3 different stools. So that's a pretty doggone extensive test. You know, if they're having diarrhea, you just swab some of the, get some of the diarrhea. If it's not a formed stool. And the reason I say to use the nun's hat is because you can't stab a floating thing. You get it? Okay.
Try not to vomit.
Try not to vomit. Yeah, it's kind of interesting. Anyway, there you go. The problem with a guaiac test, and it tests for the presence of hemoglobin, but it doesn't test for the presence of specific human hemoglobin. So if you went to the ranch last night, the hemoglobin that's still within the fillet, the 10-ounce fillet that you got, can give you a false positive here if you indeed are negative. There are other things like oxidants, vitamin C, that will interfere with the test. Menstruation, obviously, will, if it contaminates the specimen. Sampling error is big here. So anyway, the test that has evolved recently, though, is an assay for hemoglobin, specific to human hemoglobin, using a thing like a pregnancy test. And what you do here is you just take the swab, the brush that comes with this, and you just swipe the outside of the stool and use that in the kit, the pregnancy kit looking thing. And it tests specifically for human hemoglobin and is not impacted by vitamin C or animal meat. These things are available over the counter at Walgreens and CVS and places like that. You see them touted as colon cancer screening, so that's what it is. The other thing about these things is that the limitation, actually, is that, and the reason it's more specific to colon cancer, is that blood originating higher in the GI tract, like from PUD, a bleeding ulcer, is going to be digested before it gets to the back end. So it will not pick up GI bleeds, only from the colon. So it's more specific to colon cancer. That's why it's touted as a colon cancer screening rather than a GI bleeding screening. Any questions about that? You see that it is quite a bit more sensitive than a guaiac test for colon cancer screening. Okay. Now, if somebody is having GI problems and inflammatory bowel disease is on your differential, Crohn's, ulcerative colitis, or other autoimmune GI problem, one of the things you want to do is examine the stool for leukocytes, segmented neutrophils, not lymphocytes or anything, but specifically for SEGs, which are going to be present in inflammatory bowel disease. Here's a list here of inflammatory bowel disease. Some are infectious, some are not. If you suspect somebody has traveler's diarrhea, we went down to Cabo for the weekend, and I drank tea, or I drank bottled water that was poured over ice. Understand that the E. coli in traveler's diarrhea can live in the ice. I don't know how many cases of traveler's diarrhea I've seen because they used ice. You can't use anything made out of water, tap water. So they come out with this explosive raging diarrhea and abdominal cramping. That's probably going to be E. coli, not Salmonella or Shigella, but these are ones you have to watch out for as well. Non-inflammatory things are like gastroenteritis in kids. All kids at some point in the winter are going to have a gastroenteritis if they attend daycare or go to elementary school. These things are 99% of the time viral in origin. You make sure they stay hydrated. You give them a few days, and they'll be good as new. The presence of fecal leukocytes, though, will help you determine inflammatory versus non-inflammatory. you know, I've ordered fecal leukocytes in people who complain of diarrhea, ongoing diarrhea for a couple of 3 weeks, just to see, make sure I'm not dealing with an inflammatory colon problem like ulcerative colitis or Crohn's. Crohn's is most of the time going to be, happen in somebody your age. You're going to start getting flare-ups of Crohn's at a pretty young age. And this is one of the tests that will help you in that. Any questions about this? So to get this, what you have to do is, well, let me do one more thing. Let's talk about stool culture and sensitivity. You want to make sure you can rule out infectious causes of diarrhea, and stool CNS is one way to do it. Now, the way you get stool for culture and sensitivity and for doing the fecal leukocytes is you have them poop in that nun's hat again, and then you're given 2 bottles from the lab to take home with you. They're bottles about that big around, they're about 1 inch in diameter, about that long. And they'll have fluid in them, about a couple, maybe 5 cc's of fluid in them. And then they'll have a line right here. So what they'll tell you to do, the instructions are that you put stool into there until that water level comes up to here. Got it? So when the water level gets up that high, then you're good to go. Now what you want to do is you want to give them a tongue blade, or give them a couple of tongue blades, non-sterile tongue blades, to take home to scoop it out and to put in a little bottle. So otherwise they're going to use a spoon, and that's probably not a good thing. So give them a tongue blade. If it's diarrhea, they can just pour it into there to get it to elevate. Now, the culture sensitivity, 1 tube will be for anaerobes, 1 for aerobes. So they'll plate that out for you, as well as take a sample from it and do the fecal blood test. Okay?
Which one did we do in the prostate exam? The little card.
What's that?
Which one did we have in the prostate exam?
It was the
That would have been the.
That's the Hemoccult card over
Okay.
here. Yeah. The Hemoccult card, if you're doing the prostate exam, so you have the Hemoccult card, it has a little hinged flap. So you open it up, and when you take your finger out, you just smear it on both things and close it up. And then it can dry out, that's fine. You know, it can take several days for them to get it back to you. When you open the card up on the back, there's a little perforated thing that opens the card up on back. You'll have the 2 squares, you'll see the 2 squares from the back, and you'll see 2 little circles at the bottom. There's a developer that comes with the cards, and you take, you put 2 drops of developer on each one of these, and a drop here on the little circles. So if there's blood, this will turn blue, where the hemoglobin is. This one will also turn blue as your positive control. That one will stay clear or white. Okay? So that's how you develop. There are certain bacteria here that are, when you do a stool culture sensitivity, that are part of the normal screening. If you want something specific, if you think a person has Clostridium jejuni or Campers, not Campylobacter, not Clostridium, then you have to specifically ask for it. Remember that I mentioned to you this before, Campylobacter jejuni has a high rate of incidence of Guillain-Barré once they're over the diarrhea, okay? Yersinia, we don't have a lot of plague around here, but if you're concerned about it, there you go. And cholera is, has to have a special media, and as you might know, there is a huge cholera outbreak in Haiti right now. So apparently was brought there by aid workers from Europe, I think. Is that right? Somebody know that story? Is that right?
Yeah.
Yeah. It's a pretty significant thing. People, you know, and if you get cholera now here, it's not such a big deal, because it can be managed, but in places where the healthcare system is not so great, people die of cholera quite frequently because of dehydration and the infection. Testing for Clostridium difficile, this is something that you will be doing. If you have placed somebody on antibiotics and they come back in 2 weeks complaining of a raging diarrhea, well, you're the one that caused it. You have given them antibiotic-induced diarrhea. Most of the time, you just stop the antibiotic, make sure they stay hydrated, and they'll do just fine. But in a certain population here, or incidence, and it's less than 10%, they'll wind up with an overgrowth of C. difficile, which can produce pseudomembranous colitis, which can be lethal. So you have to make that call in clinic when they come back. Is this something I need to treat as just antibiotic-induced diarrhea, or something I should be worried about as a C. diff infection? You have C. diff in your colon right now, everybody does. It's just that when you take antibiotics, you wipe out all of the good, all of the rest of the bacteria and leave the C. diff to overgrow. It's kind of the same thing with bacterial vaginosis. You have Gardnerella in your vagina, you've done something though to cause it overgrowth, and that's the same thing that goes on here. In order to get the colon environment back to normal, you have to wipe it out completely, and you do that with metronidazole. Remember that. That's a board question. Metronidazole, Flagyl, is the treatment for C. diff. And you're often going to have to explain to parents or to people or patients, yes, the antibiotics have caused this, but in order to fix it, I'm going to have to give you an antibiotic, and you're going to have to explain why you're treating the cause with the same crap that you used to cause it. All right? These tests look for one of two different toxins. One is from a culture, and it takes toxin B, and it takes, you got to grow the culture out, so that takes 48 hours. The other is toxin A, which can be done with a little pregnancy test type thing in the lab. Only takes a few minutes, and you have your test results. If it's positive, you send them home with Flagyl or metronidazole. If they're toxic, you admit them and treat them in the hospital. Make sure you always follow them up in a day or two, just to make sure they're not getting worse. Okay? Any questions about that? Helicobacter pylori. This is the bug that is responsible for most ulcers, most peptic ulcers. It's not all peptic ulcers because of things like Zollinger-Ellison syndrome, but most peptic ulcers, most run-of-the-mill peptic ulcers are due to infection with this bug. And the test for H. pylori, it's a blood test, and it's looking for the presence of antibodies to Helicobacter pylori. It's looking for antibodies, which means that if you have H. pylori and I treat it, and Dr. Bondurant, I believe, mentioned the other day that, I think it was Bondurant, and he gave the treatment options for treating Helicobacter, because you have to approach it with a multi-drug treatment. You have to use a lactam plus macrolide plus Pepto-Bismol plus a PPI. I mean, it takes a lot to kill this bug. But amazingly, once you eradicate it, the symptoms of PUD really go away quickly. The problem, though, is if they don't go away, and you don't know if it's because your patient didn't take the medicine as was prescribed, because you have to treat it for 2 weeks. And if I give you an antibiotic for strep throat, and if I give you amoxicillin for strep throat, it's for 10 days. You have to treat strep for 10 days to kill it. 10 days, all right? How many days are you going to take the amoxicillin? 5 would be miraculous. 3 at best. You have not eradicated strep. It takes 10 days. But that sore throat's gone, so I'm not going to take it. I'm not going to take it anymore. All right? Well, if you don't, the treatment here is 2 weeks. It ain't 13 days, it's 2 weeks. And you have to stress the patient, you have to take this medicine exactly as it says, or you won't kill it. And they come back a month with the same complaint that they had before you started treating them. You cannot get a blood test for H. pylori because the antibodies will still be there. In order to retest them, you have to do either a urea breath test, which is done in the radiology department. They give them a radio-labeled urea, and you breathe it in, and what you exhale is urease, or something. It's some magical crap. What they're measuring is the metabolism of urea, because that's what H. pylori can do. So if it converts urea to uric acid or something, then you have an active infection. The other thing is actually going and doing an endoscopic biopsy of the tissue of the stomach or the duodenum. That's your last result. The other way you can do it, though, is with a stool sample to look for the antigen. The antigen, of course, is telling you that there is active bug in the GI tract. Okay, but you can't do a finger stick H. pylori. And here's something I learned working at Good Shepherd. We have, and I don't know if this is true or not, but it's something, we throw this out, and maybe Kim can agree or disagree. What are you eating? It's not oatmeal cream toast? I found that a large percentage, I would say greater than 95% of our undocumented folks from Mexico, one of their complaints is epigastric pain. And they are, without exception, they all have positive H. pylori. And you treat them, and they're better. I don't know if H. pylori is endemic in Mexico. Maybe our epidemiologist, is you know anything about this?
No, I don't know the epidemiology of H. pylori.
But I'll tell you, it's really remarkable. Have you noticed that?
Oh, yeah, it's great.
I mean, everybody with H. pylori.
I think they just share food so often, and it's all like, they make it, I don't know.
It was a big deal in India too. They said it had a link with sharing food and a lot of spicy food. I don't know what.
Well, I don't know about the spices, but maybe the share, you know, I don't know if double dipping, you know, transfers it into their, I don't know, but it just seems like everybody H. pylori positive. The problem is, the triple drug treatment for this is not cheap. One of the mainstay drugs is clarithromycin. Do a Hippocrates on how much clarithromycin is. It's a pretty doggone expensive macrolide. And you can't use just plain erythromycin. It has to be clarithromycin for some reason. CEA, I threw CEA in here just because you're going to encounter it with the GI tract in dealing with management of cancer, GI cancers. This is a gene that's turned on when you're an embryo, but is turned off after birth. And you normally do not express this gene that produces this protein. But certain GI tract tumors will. You know, when you think of GI tract tumors, I mean, why do you have tumors? Because you have abnormal expression of all types of genes. And that's what happens here. This gene gets turned back on and you start producing CEA. So if you've had surgery for a GI tract malignancy, and you go back every few months for monitoring, one of the things they're going to be doing is looking for the return of CEA. If it comes back, then your tumor's back. It's like in prostate. If you take the prostate out, you're measuring the PSA over time. If you have a PSA start to elevate, then you have prostate cancer that has spread somewhere else. So this is a useful test used to monitor after surgery. It's not a useful test. It's not a screening test for colon cancer. It's not a, if you have colon cancer, there's no need to get a CEA if you've made the diagnosis of colon cancer. It's only used for essentially monitoring the resolution of the problem. Sweat chloride, this is a, you will definitely have this on the boards, one way or the other. The magic number here is 60. So if you ever hear the word 60, then the first thing out of your mouth should be cystic fibrosis. You know what cystic fibrosis is? It's a abnormality of the chloride channel, the gene that codes for the chloride channel. It produces a hyper salty sweat. So what you do is they put a little patch on the skin here, like an inch or so, a patch. They apply, it's loaded, the patch has a drug in it called pilocarpine, and they attach that to electrodes. It puts a little low current through there. It's not painful, but it causes you to sweat. And when they remove that, it's assayed for the concentration of chloride. And if it's greater than 60, you have cystic fibrosis. And this can be done in the littlest of kids because it's not painful. You have to send them to the lab to do it. This is not something you can do in an office. This is sweat chloride. All right, so now we're going to talk about liver issues here. And there are two types of issues we're going to talk about. One involves the hepatocytes themselves, and the other involves the biliary system leading from the liver. Hepatocellular disease can, a patient presenting with some type of hepatocellular disease, and I'm talking about things like hepatitis, infection, or with hepatitis A, B, or C. I'm talking about cytomegalovirus, Epstein-Barr virus, tumor, hepatic adenocarcinoma, cirrhosis, destruction of hepatocytes. So all of these things represent hepatocellular disease. And people can present with a whole host of symptoms ranging from no symptoms to dead from hepatic failure. We're going to talk about most of these as we go down through here. And so let's go. On the other hand, cholestatic disease of the biliary system, again, can go from no symptoms to gray or clay-colored stools, from obstruction from stone. Kayla Evans the other day did a good job on the, at least on the video, of distinguishing cholelithiasis, ascending cholangitis, and cholelithiasis. If you don't know what those terms are, you probably need to go back and listen to that video again, or refresh your notes here. Good. Physical signs, a person with hepatitis A, other than being a little jaundiced and a little tired, they really have no physical sign, nothing is really what you're dealing with there. To all sorts of negative issues, some producing permanent changes to the body, like clubbing of the nails or the fingers, the digits. This is clubbing here. It looks like a sort of like a gecko. You can just imagine this person being able to walk up the outside of an aquarium. But these have to do, the pathophysiology here is not understood why you get these changes, but it's believed to be related to prostaglandins in hepatocellular disease, the effect on bone growth. The Shamross window is if you put your fingers together like that, if you put your fingers together like that, you'll see a little triangle, a little diamond. It's a diamond, right? Right here at the base of your nail. People with clubbing, you lose that little diamond. That's the test for. Okay. Jaundice is, it can be subtle, it can be pronounced like you see here. It most frequently will show up, I was going to say in the sclera first, but actually it shows up in the skin first. And then the sclera will turn yellow. These are a couple of pretty marked cases here. Hard to miss that. Cirrhosis. Cirrhosis is, well, it can produce not only monstrous hepatomegaly, but it can produce ascites with that. There's clearly ascites going on here as well. You see the venous dilation on the abdominal wall here. This is headed towards that caput medusae pretty soon. You get a couple of other smaller things like spider angiomata here. This is a capillary that is coming towards you, and then as it breaks out into the, it's an arteriole that's coming towards you, and then breaks out into its capillary bed, and you start to see these on the skin all over the place. Spider nevi are similar type of things, but they're, and by the way, when you see these spider angiomata or nevi, when you put pressure on them, you can blanch them. And when you take the pressure off, they come back. Spider nevi are similar to the angiomata, except there's not a specific, the body of the spider. It's more of a diffuse erythema that you see here. More like a mole rather than what looks like a spider. They get palmar erythema. Somebody showed this the other day in class. I can't remember who it was, but this does not resolve unless you get the liver issue treated. This is not a good one, and this is a good one. When you're doing palpating here, sometimes you can feel the nodularity of the liver if it's enlarged. If it's below the costal margin and you feel it, you can feel the nodules on it. I don't remember if we had a bad liver. Did we have a bad liver in anatomy? Just a little bit of enlargement.
Yeah, it was the one that was closest to the bulletin board, it was like,
Enlarged, but it was still smooth though, right?
yeah.
Yeah, these things, they get, what's happening here is that if you look at the architecture of the liver, you have a core, a canal. To say, we have a canal. And in that canal, there'll be blood vessels and the biliary, what will eventually give rise to the biliary tree. Surrounding that canal is a grouping of hepatocytes that feed into it. Kind of like the bone, the Haversian canals of, and systems of bone. It's kind of like what it's like here, with just hepatocytes. These nodules are what happens when you get, the hepatocytes are swollen and are replaced with scar tissue. That's what they produce, these little nodules in hepatocellular disease. This is end-stage liver disease. You're going to see a lot of people like this. This is a person, this guy's going to die. You can see he's jaundiced, he's got ascites, his liver is no doubt huge. He doesn't have much longer to go. It's tragic to see somebody die of liver failure, but it's a slow, painful death, but you're going to see a lot of people with it. The only way it's going to be corrected is with a liver transplant. They don't do those in alcoholics or drug addicts. And other than Mickey Mantle, you know, Mickey Mantle, the baseball player, he was an alcoholic. He wound up with alcoholic liver disease. Looked like this. He got a liver. You think that was on the up and up? No. I think about that every time I go by Mickey Mantle's downtown, that somebody was screwed out of a liver. So, anyway, portal hypertension, we went over quite a bit in anatomy. You understand that all of these structures are going to drain into the liver through the portal vein, and from there straight to the heart after they pass through the hepatocytes for processing. If you go through and look at the portal circulation, you remember you've got the hemorrhoids down here, you've got the caput medusae out in the umbilicus, and you've got the esophageal varices up here at the gastroesophageal junction. Now, in looking at the causes of morbidity and mortality related to liver disease, the Child-Pugh formula is like Ransom's criteria, but looking at different things. One is you're looking at bilirubin. Bilirubin, of course, you know, is where the liver is going to process unconjugated to conjugated bilirubin. So you're looking at bilirubin levels. Albumin, you know that the liver produces albumin, right? Remember that. The liver produces albumin, as well as vitamin K-dependent clotting factors, which is assessed through a PT or an INR. The presence or absence of ascites and the presence or absence or degree of hepatic encephalopathy is placed into this formula. You're assigned points, and your mortality is determined by the number of points. You can see here that your 1-year survival, if you have 10 to 15 points, which would be over here, 5 times 3 is 15. You're looking at half of you will be dead in 1 year. So liver disease is pretty ugly. 2-year survival is even worse. urinalysis. Want to touch or retouch on a couple of things regarding bilirubin in the UA. Remember that it's only conjugated bilirubin that is filterable. It's conjugated to a diglucuronide molecule. The unconjugated is still conjugated, but it's to albumin. Anything conjugated to albumin is not going to show up in the urine. Urobilinogen, you normally have a small amount of urobilinogen. Remember, you make urobilinogen once bilirubin has passed into the gut. The GI bacteria convert that to urobilinogen, and it can be reabsorbed and show up in the dipstick. Now, an absence of urobilinogen with an elevated bilirubin, either serum or in the urine, tells you that there is an obstruction in the biliary tract and that no bilirubin is getting into the GI tract. You need to review that and make sure you know it and love it. For just old time's sake, I put this back in here. Make sure that you understand that process there. Things to know. Most of the time, you're going to hear the words conjugated and unconjugated, but some of the old timers will still use the word indirect and direct bilirubin. So you need to know what those are, which ones are which, and I'll put them here. There are a couple of things that, in terms of the coloration of ecchymosis here, as bilirubin or as hemoglobin is processed in the tissues here. Bilirubin is yellow, biliverdin is more of a greenish appearance. One thing you always want to note, just in this state in particular, since we have a huge problem with domestic violence and child abuse, is that whenever you have ecchymoses or bruises in various stages of healing, you've got some yellow, some green, some black, some red, then you need to, what should be on your differential is abuse. Okay? We know about the yellow skin and jaundice. Yellow sclera is called icterus, I-C-T-E-R-U-S, icterus. I think that's how you spell it. Brown poop versus clay colored, and as I mentioned when we went over this before, that's East Coast clay, not Oklahoma red clay. You need to keep that in mind. One of those catfish weighed 8 pounds. That was a big catfish. Finally, yellow pea versus tea-colored. Normally your pea should be yellow. Tea-colored pea is pathognomonic for an excess of bilirubin. Anytime you hear the words tea-colored urine, you're talking about hyperbilirubinemia. Now, most of the time when you get a CMP, you're not going to get a total direct and indirect, or unconjugated and conjugated. What you're going to get is a total and then one of the two others. To get the other one, it's what's left. The amount of conjugated and unconjugated bilirubin is about the same. So, there you go. Now, when you're looking at bilirubin, one of the things you need to consider here, or one of the aspects is it due to a hemolytic condition, like sickle cell disease? If you're having premature rupture of red blood cells, like in sickle cell disease, which is a hemolytic anemia, if you have a massive hematoma, if you've been in an MVC and you have bruising all over your body, road rash, for example, a lot of bruising. The absorption of bilirubin over time can elevate it, and excessive erythropoiesis. Biliary obstruction, it comes from basically stones or cancer, and in intrahepatic things would be things that I mentioned early on. Now, this list is somewhat limited versus you need to make sure you include CMV, cytomegalovirus, hepatitis. Now, jaundice, the presence of jaundice, normally your bilirubin level is, total bilirubin level is around 1 to 2. Again, 50-50. When it gets above 3, the eyes turn. 5, well, this is saying the eyes turn first. I always, when I see people with jaundice, I can pick up jaundice faster than I can pick up icterus. I don't know. It's a descending type of coloration. It takes less amount for your face to turn than for your feet to turn. If you look at the beginning of this discussion about liver, it always mentions pruritus. Bilirubin deposited in the skin makes it itchy. One of the biggest complaints of these people, the biggest complaint of somebody with hepatitis A is the itchiness of their skin. And you have to eventually, you can treat that systemically with antihistamines really, but you gotta get the level down. And usually in hepatitis A, that means time before the itchiness will go away. Newborn jaundice, did you guys cover this when you did OB? Okay, so almost all newborns when they're born, they don't process bilirubin correctly. And their bilirubin, their total bilirubin will start to rise. Breast milk actually has inhibitory factors in it that make hyperbilirubinemia in the infant worse. So if you wind up with newborn jaundice, if the bilirubin starts to rise, and after birth, you're going to be checking for a bilirubin in the infant. If it starts to rise, what you want to do is take the child off breast milk and put them on formula for a few days as you monitor the bilirubin go down. You want to pay attention to this. You usually don't screen for bilirubin, but if it's something you notice, and you notice this usually before they go home. So if you notice the presence of jaundice in the infant, within 48 or 72 hours, you're going to get a bilirubin level. If it exceeds this here, then you're going to place them under what are called biliolights. It's basically just a plant growth thing, you know. The ultraviolet radiation degrades the bilirubin in the baby's skin and will drop the bilirubin level. So you might have them under biliolights for a few days to get their bilirubin down. If their bilirubin exceeds 20 milligrams per deciliter, that's pretty much a medical emergency there. If it gets up here around 25, it can produce long-term complications, including delayed, it says mental retardation, but that's kind of really not a politically correct word or phrase, but you understand what I mean. And here's a little bit more of an explanation of the biliolights. I would say probably 5% of infants are gonna wind up having to utilize Billy lights before they go home. And you can also, if the bilirubin starts elevating before the first well child check, usually you have them back in the office a few days after they go home, you can get Billy lights as durable medical equipment brought to their house and have them under Billy lights at home as well.
My niece, that was born this last semester, she, had that, and they put her, the OB just said to put her near the window.
Yeah.
I guess she wasn't elevated too high.
Yeah, it wasn't elevated too high.
And, I mean, she was a little yellow, but, yeah, in a couple days, her labs are back to normal.
And most kids, I mean, almost all kids wind up with neonatal jaundice. It's just that when it gets too high, then you have to do something about it. I always is think of them as like little African violets. You know, they're always under the lights, or, you know, they're like the sunshine. African, you know what African violets? You guys don't know what an African violet? Jeez.
This is not about you.
The what?
Okay.
Communist again. It describes, whoops, it describes here these long-term problems. When you have neonatal jaundice, it's called kernicterus. All right. Can we keep going, or do we need to take another break? Keep going. Okay. If you need to go, just go. So, liver enzymes. You hear these referred to all the time as liver function enzymes. They are not liver function enzymes. They do not tell you how the liver is functioning. They are just like the pancreatic enzymes we just covered. They're intracellular enzymes that should be inside the cell instead of in the serum. One of them is alphos, or alkaline phosphatase. I don't really care that you know what the function of the enzyme is. I want you to know more how to use it and what it means if it's elevated. Alphos is found in the liver, but it has a concentration highest in the biliary tree. So the bile ducts, the right and left hepatic ducts, the cystic duct, common bile duct, have high levels of alphos in those cells. You also have alphos in bone. Alkaline phosphatase is in bone. If you have a malignancy of bone or destruction of bone, your alphos will elevate. So you have to make sure that if you have an elevation in alphos, is it coming from bone or liver? And the way you tell is you look at the other liver-related enzymes that we'll talk about here in a second. The placenta also has alphos, but really, who cares? The thing here about alphos is it's most sensitive in telling you about obstructive extrahepatic liver disease, meaning the bile duct is obstructed. Or there's obstruction from pancreas, cancer of the head of the pancreas. Any obstruction of the bile duct system. It elevates much higher than anything related to hepatic cause. This is your number one. If you have somebody with suspected gallstones, you want to get an alphos. And it's part of a CMP. So it's not something, oh, I need an alphos. Get a CMP, because that's going to tell you about all the liver enzymes, not just this one. Bone ALP, again, I mentioned tumors, Paget's disease of the bone. Remember that I believe we talked about this when we were doing bone back in musculoskeletal. Paget's disease of the bone looks like a mixed madness it's just laid down everywhere. Outfos will elevate in that situation. You confirm that outfos is from the liver or from the duct with a GGT. GGT is gamma glutamyl transferase, that's on the next slide, also called GGT, well, formerly called GGTP. This used to be a very popular test for alcoholism because it's sensitive to chronic ingestion of alcohol. Or if you went on a binge on the weekend, you could get a GGT on Monday and it would be elevated. But it's sort of fallen out of favor now as a measure of alcoholism, preferring you don't want to get a lab test, an elevated GGT, and say you're an alcoholic. You're looking at alcoholism more from the behavioral perspective. That's more the way you do it now. So this is not part of a CMP. You would have to specifically request a GGT if you're looking at is outfos from the liver. Now, here are the big ones. AST and ALT are the two big liver enzymes we want to pay attention to. Outfos is more the biliary tree. This is more hepatocellular. It says formerly SGOT versus SGPT for ALT. So ALT was formerly SGPT, and AST was formerly SGOT. I don't know how many more years they're going to keep putting this damn designation in there. That thing hasn't been used in 20 years. Why do we still say it was called this? Forget it. Just use the term AST and ALT. All right? Now, AST comes from a lot of different places. Primarily from the liver, but from a lot of other places. This thing is a sensitive marker for liver disease or liver cell death, hepatic cell death. You confirm that it's liver origin by getting its sister test, the ALT. So they both rise pretty much together, one more than the other in liver disease. And here's ALT, also formerly known as the artist Prince. Wasn't it tragic how Prince died? You know, it's that fentanyl-laced heroin, I think is what he got into. I was watching Drugs, Inc. the other night on TV. Did I tell you about this? Drugs, Inc. about the heroin epidemic we have now that's it's down here in Oklahoma. They were interviewing a drug dealer on Staten Island. So he had all of his dime bags of heroin, and what he would do, like every 10th bag, he would put a couple of extra drops of fentanyl in there. That the addicts that got the fentanyl bags, they were going to overdose. Yes, but the thing is, as a group of addicts, if we know that Kayla overdosed, she must have gotten a hold of some good shit. And no kidding, he used this as a marketing ploy. The 10% of the people he sold these bags to were going to wind up in the ER or dead. Just so that the other addicts could say, that's some good stuff. Kayla must have gotten into some good stuff. That's incredible.